day. My name is Shema Abdraman Abba, also known as your heartbeat doctor. So today I'm going to make a review on my new book on heart failure. I'll pick the most important aspect of the book. Well, although I'm going to go through it, but I'm not going to talk much about them. So before we start, let's go through the outline of the book. So in the outline we have definition of heart failure, we have epidemiology of heart failure, precipitating factor of heart failure, we have classification of heart failure based on echo, based on duration, and based on chambers. We also have pathophysiology of heart failure, what used to make the heart, when the heart is decompensated, when we make the heart to compensate. So after the pathophysiology, we go about the complication, we go about the management, and then we talk about the treatment. We talk about the clinical manifestation, Then we go about the investigation, we talk about the treatment. In the treatment, I'll discuss about the management, pharmacological management, and non-pharmacological management. Okay, now let's begin. I'm going to define heart failure. According to WHO, heart failure is a clinical syndrome characterized with symptoms and signs as a result or caused by functional or structural cardiac disease, and corroborated with natriuretic peptide elevation with an objective evidence of systemic or pulmonary congestion. So this is the most important, if you know this definition, this is the best definition of heart failure according to WHO. So in Nigeria, we are going to start off, the next step is epidemiology of heart failure. Since we define what is heart failure, I said it's a clinical syndrome. So we said we have symptoms and signs. As a result, it can be functional or structural cardiac disease, especially maybe it's mitral valves, stenosis, or regurgitation. And then we said with an objective evidence, it can be systemic or pulmonary congestion. Later I'm going to discuss in the video. So we talk about the epidemiology of heart failure. So in Nigeria, here in Nigeria, the epidemiology is more common in male after the age of 65. So according to WHO, in Nigeria, the epidemiology of heart failure is more common in elderly, which are 65 years old. But in 2010 to 2015, but from 2015 to 2021, heart failure is not common in elderly, it's more common in patients also under 45 years old. So we start with etiology of heart failure, since I define what is heart failure. So what's the etiology of heart failure? Etiology means what's the cause of that disease, what's the cause of the heart failure. So we have, number one, we have hypertension, 66% is one of the most common cause of heart failure. We have dilated cardiomyopathy, we have ischemic heart disease, I didn't even conclude it inside the book. We have rheumatic heart disease, APC. So what's the most common cause of heart failure worldwide? Is hypertension. Well, let's differentiate it. Since we said worldwide is the most common of hypertension, but in Africa we have what's the cause of hypertension, we have heart failure, and in Asia we have the cause of heart failure. So in Nigeria, West Africa, the most common cause of heart failure is hypertension. 99% is hypertension. I'm going to discuss later how the hypertension progresses to heart failure. Why in Asia the most common cause of heart failure is ischemic heart disease. So see the differentiation now. The most common cause of heart failure in Nigeria is hypertension, while the most common cause of heart failure in Asia is in United States, in UK, is ischemic heart disease. We have dilated cardiomyopathy is also a common cause of heart failure in Nigeria, and also we have rheumatic heart disease. So we have the precipitating factors of heart failure. What the precipitating factor means, how does that disease progress to heart failure? We have anemia, more especially in children, alcohol excess, we have pregnancy. In pregnancy, we call it peripartum cardiomyopathy. It's one of the most common cause of heart failure, which normally present at the third trimester. And we have acute myocardial infarction, also one of the most common cause of heart failure. And then we have enterotoxicosis, which is also one of the most common cause of heart failure. But here in Nigeria, anemia, alcoholic excess, pregnancy is one of the precipitating factors of heart failure. So we have the risk factor of heart failure. Risk factor means how does how, let's say in incident, the way I explain incidents, risk factor means how does it, since we say precipitating factor, how did the disease progress? Risk factor means what should we avoid what should we avoid in order to get heart failure or in order to diagnose with heart failure. So we have dyslipidemia, we have age. Also, I told you example, 65 years in middle age. Now it's more common in middle age, and then in elderly. We have family history, sedentary lifestyle. And we have classification of heart failure. Classification of heart failure. Normally, heart failure is classified into 3 parts. We have in the classification, we have classification of heart failure based on echo, classification of heart failure based on duration, and we have classification of heart failure based on chambers. We have based on left and right chambers. So now I'm going to take time and explain classification of heart failure based on echo. So this classification of classification of heart failure based on echo, according to American College of Cardiology, is now divided into 3. Before it was 2, but the new system now said it's 3. So in heart failure, we preserve ejection fraction. That's normal ejection fraction is 50% upward. So patient present with heart failure, the ejection fraction is preserved. And then we have heart failure with reduced ejection fraction. We said the ejection fraction should not be less than 40. Sorry. And then we have heart failure with mid-range ejection fraction. This one is less than 39. In this heart failure with mid-range ejection fraction, nobody knows the causes. Anything can cause, DM can cause, hypertension can cause, but in US, the most common cause of heart failure with mid-range ejection fraction is ischemic heart disease. So now let's begin. What is heart failure? Sorry. How can we, let's explain heart failure with preserved ejection fraction. So heart failure with preserved ejection fraction previously refers to as diastolic heart failure. That means patient with heart failure with preserved ejection fraction, as I told you, the ejection fraction is greater than 50%. So this type of, the most common cause of that heart failure with preserved ejection fraction is hypertension in elderly. So patient in elderly will present with heart failure, have normal symptoms of heart failure, but on echo or under the echo machine, after doing the diagnosis on echo, you see the ejection fraction and the left ventricle is up early. You see the ejection fraction will be greater than 50. Normally you find maybe 75%, 80%, but the patient is having symptoms of heart failure. But this type of heart failure with preserved ejection fraction cannot lead to sudden cardiac death. Maybe there are many causes of heart failure with preserved ejection fraction, apart from hypertension. But the most common cause is hypertension. Elderly patient present with hypertension. So this is the most common cause of heart failure with preserved ejection fraction. Not in Nigeria, in worldwide, hypertension is the most common cause in heart failure with preserved ejection fraction. But apart from that, patients with heart failure with preserved ejection fraction have ejection fraction that I told you is greater than 75. But there's a left ventricular diameter. Left ventricular diameter should not be greater than 60. But patients with heart failure with preserved ejection fraction will have left diameter with greater than, let's say, 65 and 60, because I will say that the ventricle is normal. The ventricle size is normal, but there is a ventricular dilatation. That's why I told you the ventricle, if you come to diameter, the ventricle is greater than 60. Normally it should not be greater than 60. So there are many causes of that heart failure with preserved ejection fraction with normal ventricular size and with ventricular dilatation. We have anemia is most common, hypertrophic cardiomyopathy. In echo, you'll be seeing the interventricular septum. What we mean with interventricular septum is a septum between the two ventricles that separate the ventricle, that separate the right ventricles from the left ventricle. You'll be seeing it hypertrophied, you'll be seeing it vertic. We have also anemia, we have restrictive cardiomyopathy, and then we have the constrictive pericarditis. But the most common, I would say, is hypertension and hypertrophic cardiomyopathy. The hypertrophic cardiomyopathy is one of the most common causes of heart failure with preserved ejection fraction. Patient will present with normal ejection fraction, but the left ventricular diameter is, the left ventricular size is normal, but the diameter is greater than 60 under echo. So heart failure with reduced ejection fraction. This heart failure with reduced ejection fraction is called the systolic heart failure. The most common cause of heart failure with reduced ejection fraction is ischemia. That means the ejection fraction is less than 40. Normally it should not be less than 40. It's from 40 to 50 upward. But this in this patient, under the echo, the patient presents with heart failure with reduced ejection fraction. So normally, before I continue, when you're now clocking a patient after final diagnosis, you won't say the patient have heart failure with preserved ejection fraction or heart failure with reduced. It's only under the echo when you own the echo machine and start the process, and after you start the process is where you find out that the ejection fraction is greater or lesser. So a patient with heart failure with reduced ejection fraction normally present with ischemia or increased pressure or volume load. This increased pressure or volume load normally, before I continue, in hypertension there is one formula we normally use, which is that BP equals to cardiac output times total peripheral resistance. When there is high total peripheral resistance, and there is low cardiac output, and there is high blood pressure, this is the most common cause of heart failure. It can lead to heart failure because of the total peripheral resistance is narrowing. There is no problem with the cardiac output. The heart tried to compensate so that the aorta will eject the blood, but the total peripheral resistance is narrowed. So when blood wants to pass, it will be very hard. So the ventricle try to compensate, but later now the ventricle become floppy. I'm going to explain later in the video, but I'm just telling you that I'm going to explain heart failure with reduced ejection fraction so that you cannot be confused. So when I tell you heart failure with reduced ejection fraction, the most common cause is ischemia or increased pressure or volume load, and I explain what is that. Result in reduction in cardiac output. This reduction in cardiac output can trigger the renin-angiotensin aldosterone system in kidney. This renin-angiotensin, since the patient presents, let's say, with heart failure and reduced maybe with hypertension and low blood pressure, but this renin-angiotensin trying to compensate, this cardiac output now triggers renin-angiotensin aldosterone system. It will make the heart to compensate. So this RAS, renin-angiotensin aldosterone system, now will activate the sympathetic nervous system. And the rule of sympathetic nervous system is to increase the blood pressure. This increasing the blood pressure, it can lead to systemic vasoconstriction. And also, RAS is not only to activate the sympathetic nervous system to increase blood pressure, it can result in salt and water retention. And after that, when the RAS activates the sympathetic nervous system will go and increase the blood pressure. But the most important thing, what you have to know, the difference between heart failure with preserved ejection fraction and heart failure with reduced ejection fraction. Heart failure with preserved ejection fraction is more common in elderly patients. In elderly patients who present with hypertension, but there are other causes of heart failure with preserved ejection fraction, which I tell you, it can be hypertrophic cardiomyopathy, it can be anemia, and then it can be pericarditis. But in heart failure with preserved ejection fraction, another thing that you have to know and put it at the back of your mind, patient will present with ejection fraction greater than 50. Patient can present with 75% of ejection fraction, but also check the left ventricular diameter under the echo, because some of them they can present with heart failure with preserved ejection fraction, but you see the ventricle diameter is not normal while the ventricle size is normal. So the ventricle size will be normal, but diameter will be greater than 60, and normally should not be greater than 60. So in heart failure with reduced ejection fraction, the most common cause is the ischemia or structural valve disease. Then put it, because if I said increase pressure or volume load, people can be confused about it. But the most common cause of heart failure with reduced ejection fraction is ischemia. So this one I'm going to spend time on it also. We have heart failure related to chambers or heart failure based on chambers. But how can you, when they ask you, just say heart failure related to chambers. So, but now in modern society we use heart failure based on echo. Before we used to use based on chambers, related to chambers, but now we use based on echo in Nigeria and in worldwide. So let's discuss heart failure related to the chambers. We have the left heart failure, and we also have the right heart failure. So what's the cause of the left heart failure? So in left heart failure, they say there is a reduction in the left ventricular output, and there is an increase in left atrial and pulmonary pressure. How? BP is cardiac output times total peripheral resistance. So this total peripheral, when there is increase in this total peripheral resistance and there is increase in BP and decrease in cardiac output, this is how hypertension can lead to heart failure. How? So when there is high total peripheral resistance, the left ventricle, sorry, let me pick this one and explain to you. Patient with left heart failure. So in left heart failure, there is reduction in left ventricular output and increase in left atrial and pulmonary venous pressure. How? Normally in hypertension, we said the normal formula we use in hypertension as a medical student, one I know is that BP equals to cardiac output times total peripheral resistance. High total peripheral resistance and high BP with low cardiac output can cause left heart failure. How? So let me explain by using the stethoscope. Let's say this is the ventricle and we have high total peripheral resistance. So this left ventricle will try to compensate by increasing the pressure in systemic vessels. Left ventricle will try to compensate by increasing the force of contraction. So this is the left ventricle and this is the atriolus. So the left ventricle will now try to increase resistance with repeat increase in contraction. It will now, the muscle will now come and contract. So this left ventricle will contract. We use it. The left ventricle will now try to compensate by increasing in contraction. So the muscles will now contract very, very hard, so that the blood will reach the demand of the body supply, so that the blood can reach the atriolus. So you know, atriolus are small arteries that are closed. They also have gate-like channels. This gate open when the blood come and the blood will flow out, and when the blood is not coming, the atriolus close. So when there is constriction, incomplete opening of the ventricle of the atriolus, let's say a little bit like this. So the blood will now try to push up to pass through the atriolus, but the blood cannot because of the total peripheral resistance are narrowed. So this ventricle, the left ventricle now, this is the left ventricle now, will try to push the blood by force to pass through the atriolus. But the ventricle will try its best to increase the contraction, will try to push the blood to pass through the atriolus. But these atriolus, because they are very narrowed, the blood will now fail to pass. So this ventricle, as you know, in left ventricle we have thick muscles, and this thick muscle contract very, very fast. So the muscles in the left ventricle will keep contracting. Let's say this is the muscles and this is the blood. Will keep contracting and blood will be flowing, but the atriolus is still narrowing. The muscles, left ventricular muscle, the left ventricular muscle keep on contraction to the extent that it has now reached a stage that the muscles become weak. So as the muscles become weak, there's no much contraction, but there is no more contraction. So the ventricle become very weak. We now move to right heart failure. The right heart failure, the most common cause of right heart failure is the left heart failure. Apart from that, we have the core pulmonary, which is a chronic lung disease, pulmonary edema, and pulmonary vascular stenosis. So in congestive heart failure, or we call it biventricular failure, but now modern we call it congestive heart failure. The most common cause of that is left and right heart. Left and right heart may develop in congestive heart failure because the disease process, such as dilated cardiomyopathy, dilatation of the four ventricles, when the four chambers are dilated, blood cannot be ejected. Or ischemic heart disease. In ischemic heart disease, we have long-standing ischemic heart disease, why we call it ischemic cardiomyopathy, which is common in US. But in Nigeria, dilated cardiomyopathy can cause hypertension, and from that it can progress to congestive heart failure. So we now started with symptoms of heart failure. In these symptoms, I'm going to differentiate the left heart failure, the right heart failure, and the congestive heart failure. But before we begin, let me list them out. We have the bilateral two-leg swelling, paroxysmal nocturnal dyspnea, and then we have autopnea, cough, easy fatigability, and upper abdominal pain. So how do you differentiate patient with these symptoms is heart failure, left heart failure, right heart failure? Don't forget I told you, patient with heart failure, left heart failure normally present with pulmonary edema and congestion. So let me list the symptoms. Patient with left heart failure can present with cough. I told you, let me just explain why the patient present with cough. If the pulmonary capillary have high blood, the pressure in the capillary is higher but there is no rupture, patient can present with cough. So if patient present with cough, that means the pulmonary pressure is higher but there is no rupture. But when patient present with hemoptysis, we used to call it presence of vomiting of sputum, there's bloody sputum, or let me say or bloody sputum, there's a rupture of the pulmonary capillary. Well, let me distinguish, don't be confused. Patient with left heart failure can present with what? Cough or autopnea. Autopnea means sensation of breathing. Patient cannot breathe. Patient cannot breathe until he wake up, or patient cannot sleep with high 1 filo, because patient if patient sleep with 1 filo, there will be increase in afterload and preload. So the patient will have 2 to 3 pillows infected, so that the patient can have breathing sensation. Or patient present with paroxysmal nocturnal dyspnea, that's a condition that triggers difficulty in breathing at night. Patient can be sleeping very. Patient is in deep sleeping, but patient will wake up. The difference between autopnea and dyspnea, patient will sleep. In autopnea, patient will just sleep, will not sleep with 1 filo unless it's 2 to 3 filo, so that patient will have sensation of breathing. Present with bilateral leg swelling. Normally we said the hallmark of right heart failure is the ankle swelling. From the field, you will see ankle is swell up. Bilateral leg swelling in patient with right heart failure. Patient will present with easy fatigability. Patient will present with right upper quadrant pain, or we call it upper abdominal pain. So we now move to the treatment. In treatment, we have the non-pharmacological finding and pharmacological finding. In non-pharmacological finding, you have to tell the patient this as a physician or as a cardiology. The patient should reduce the alcohol intake, should reduce the salt intake. The salt intake, there's sodium, so that it will, and if you know if there's presence of sodium, too much sodium can cause retention of salt and water. So patient can reduce salt intake. Mild exercise, and patient can tolerate water restriction in severe cases, especially patient with right heart failure, congestive heart failure. We said, doctor, whenever I ate too much, well, let's say when I eat enough food, I'll be seeing my abdomen. It has been swelling up, and I'll be feeling pain at the right side of the abdomen. So before I say this is the end of the class, let's talk about the pharmacological finding. This pharmacological finding is very, very important. So now, according to American College of Cardiology, there is 5 pillars of treatment of heart failure. These 5 pillars treatment of heart failure, we have the diuretic, and this diuretic decrease afterload and preload. This furosemide, and we have the thiazide and the loop diuretic. In this thiazide, normally the thiazide, the mechanisms normally inhibit the sodium chloride reabsorption in distal and thick ascending loop of Henle, while in the loop of Henle normally inhibits the chloride reabsorption in loop of Henle. We have the furosemide in the loop diuretic. We have the furosemide, bromotenide, while in thiazide we have the hydrochlorothiazide and indapamide. These drugs will be. Let me make some. Before we close, I will talk something important, but let's continue. So with the side effects, normally this diuretic will normally give the patient that present with heart failure so that to excess the fluid. And this diuretic should not be taken at the night, you should be taken at the daytime. So the side effect, we have the hypokalemia, decrease in potassium, hyponatremia, decrease in sodium, it can cause hyperuricemia, increase in uric acid. And then we have the AC inhibitor, angiotensin converting enzyme is the first line of drugs given to a heart failure patient, because it decreases systolic blood pressure, especially patient with heart failure will reduce ejection fraction. So we give you captopril, lisinopril, candesatan, losartan, and telmisartan. In Nigeria, we give captopril, we give all of them, they are most common. But the side effect, patient can have headache and hyperkalemia. So aldosterone antagonist, as this aldosterone antagonist is also very important. It inhibits the sodium reabsorption in distal, because we need the potassium and excrete the sodium. So that's what its job. Aldosterone antagonist, or we call it potassium antagonist. It inhibits it's now. How will I even explain to you the work of? Just know know that it's a potassium antagonist, or we call it aldosterone antagonist. This is the main family name, because sometimes they used to confuse students during word round. They will ask you what is the pick spironolactone and tell you what is the family name. So you can, you're supposed to take potassium antagonist, you say aldosterone antagonist. So the side effect is hyperkalemia, hyponatremia. So this aldosterone antagonist should not given to a patient without using the echo, unless there is echo result and patient has the ejection fraction is greater than 40. Patient cannot take spironolactone. But when the ejection fraction is less than 10, is less than 40, patient should be on aldosterone antagonist. And patient with heart failure, when you diagnose, you see the patient having heart failure, don't give the patient aldosterone antagonist unless the echo unless the echo result is out before you prescribe spironolactone. Either you can give the patient spironolactone, or you cannot give the patient the spironolactone. And spironolactone is under aldosterone antagonist. Side effect: hyperkalemia, hyponatremia. We have the beta blocker, which can decrease the blood pressure, can inhibit the sympathetic nervous system, can give carvedilol, is more common given to patient with heart failure. You can also give bisoprolol and metoprolol, but carvedilol is more common here in Nigeria, or let me say worldwide. And we have side effects, we have hypertension and bronchoconstriction. So you cannot be given to patient with asthma, in asthmatic patient with heart failure. So another drugs that has been added, we have sodium glucose co-transporters inhibitors. We have ganagliflozin and dapagliflozin. This drug is more expensive, it's very expensive in Nigeria. It's common but not that common, because some patients cannot afford to buy it because it's too expensive in worldwide. An increase in urinary tract infection and increase in genital candidiasis. Candidas. So multiple complication of heart failure can be multiple organ damage, shock, failure of blood circulation, that's shock. We have patient can present with atrial fibrillation, cardiorenal syndrome, sudden cardiac arrest, stroke and thromboembolism, etc. But don't forget, in all this video, these are the 5 pillars that you're supposed to know. We have diuretic, we have the AC inhibitors, beta blocker, aldosterone antagonist, and we have the sodium glucose co-transporters. These are the 5 pillars that you're supposed to know as a medical student. But before I say goodbye, this is the most important thing that you have to know. Don't prescribe spironolactone to a patient unless the echo result has shown you that the ejection fraction is less than 40. But when the ejection fraction is greater than 40,